Hi, everyone. Welcome to today's Podinar with my dear friend from Italy, Dr. Armando Minchiarelli. Hi, doctor. How are you?
I'm fine.
Before I start introducing him, let me speak about some initiatives we are taking at the Global Summits. The Universal School of Health is a new reality, and as first initiative, we are starting the Doctorate of Healthcare Business Program, DHB. I'm proud to introduce the first program in the world that closes the gap between clinical training and real-life business acumen for doctors, empowering us to be successful CEOs and community leaders. As healthcare professionals, we all go through rigorous training, achieving clinical competency over years of professional education. But however, it is not possible to fit business training into our already demanding clinical curriculum. So recognizing this gap, we are offering this program to help doctors rise to their next level of business excellence. Our program is taught by clinical professionals who also own and run successful businesses, including myself. These doctors come from all over the world and have backgrounds in research, publishing, innovation, team building, sales, psychology, business scaling, and marketing. This unique team will be augmented by outstanding global industry leaders as guest lecturers who will share cutting-edge knowledge in their respective fields. For several weeks, we are now, and you were also now, able to hear the podinars from many of the main lecturers of DHB, and we will continue to do so for the next month also. If interested, please contact us as soon as possible to profit from preferential fees, and we will also offer several scholarships. Also, another point that I wanted you to let you know is the Hippocratic accreditation. Which is accreditation by doctors for the healthcare industry without the corruption. In the last few decades, third-party service and product organizations have grown around accreditation organizations, professional schools, finances, politicians, lobbyists, regulatory bodies, and whoever can exert their influence directly or indirectly interfering with the sacred patient-doctor relationship. The noble professions have become more in a marketing function, and the public has lost faith in its professionals and the healthcare industry. So this trust must be restored. Hippocratic principles are the premise of our oath and obligation to patients and the healthcare industry. First, do no harm. Though leaders, namely doctors, should continue to guide the destiny of the noblest profession, as we have done for thousands of years. As we enter a world of globalization and integration in healthcare, domestic accreditation bodies do not have any significant oversight, which has led to corruption and to uninvited corporatization of the healthcare industry. For the benefit of a few, monetary gain has become the greatest priority for those, and no fraternity, regardless of taints and scientific method, and the sacrifice of healthcare professionals and their patients. To reestablish this, the Global Summits Institute, composed exclusively of leading doctors, dentists, pharmacists, optometrists, chiropractors, and healthcare philosophers, as nominated by their peers, will be offering Hippocratic accreditation to any of the organizations deemed worthy of this seal of approval, including universities, insurance companies, pharmaceutical companies, service providers, regulatory agencies, product distributors, hospitals, private practices, domestic or international, operating within the healthcare supply chain. This mark is earned by the organization and will inform doctors and patients worldwide that the organization has undergone a thorough review process and does not infringe upon their inherent rights and relationship. So I'm glad now to introduce Dr. Armando Francesco Minchiarelli. Dr. Minchiarelli is an Italian oral surgeon and expert in dental prosthesis, and oral oncology. He has graduated from the University of Bari, and he mainly deals with multidisciplinary complex surgery implant treatments. He is an expert in impacted teeth surgery and all oral surgery. He is a speaker in numerous courses and conferences in Italy and abroad for these issues. He works in his clinic in Bari, southern Italy, and he is also a scientific consultant for clinical research. But what is more to know is that Dr. Minchiarelli is married to an Albanian woman, and since he is so, I know him from many years, and we had the pleasure to meet in different conferences in Albania and in Italy. So, Dr. Minchiarelli, how are you today?
Thanks, I'm very, very well. It's possible to start now?
Yes, of course it is. So your topic is very interested. Can you please tell us a couple of words what are you going to talk about?
I talk about with sinus lift treatment, technique and procedure.
Okay. So please share the screen with us, and good luck for this event.
Okay, thank you. Allora, condividi. It's okay?
Okay.
Okay. Good morning, good afternoon, and good evening, everyone. I am very honored to have been invited to speak for the Global Summit Academy of Oral Surgery and top 100 doctor in the world. Thanks to Dr. Kionor Shah and my friend, Dr. Guillem De Miraci, for giving me the possibility to be here in front of you. Today's topic will focus on sinus lift technique and procedure, but first I would like to officially introduce myself to the scientific community. My daily practice consists of the management and implementation of complex multidisciplinary prosthesis, oral surgery, implant prosthetic restoration, and oral oncology. There are many techniques related to sinus lift, and it is important that the clinician is able to select the right technique for each individual case. My belief, it should be used by the clinician when the possibility of using alternative technique are scarce. To begin, talk about technique and procedure for the large maxillary sinus lift. It seemed right for me to speak about the anatomy of the sinus. The right understanding of anatomy ultimately leads to excellent surgical technique. These are focused on achieving correct prosthetic procedure with complete and effective management of any complication. Sinus pathologies are usually considered to be maxillofacial surgery, but are often related to the stomatognatic system with the anatomical relationship of contiguity. The jaw sinus, or cavern of Highmore, is the largest paranasal cavity and is contained in the body of the maxilla. Its development is related to a process of functional pneumatization of the bone in the facial block during the growth of the skull in the postnatal period. This then slow down in the period of puberty until the 5-6 years of life, and then resumes in old age. This is when the maxillary sinus reaches maximum volume, about 30 cc. It's very variable in shape and size, from aplasia to hyperneumatization. The average volume is about 20 cc. The maxillary sinuses are frequently asymmetric. Anatomical variability is from 3 cubic centimeter to 35 cubic centimeter. It is a shape of a quadrangular pyramid with the apex direct, lateral, at the zygomatic bone. The frontal area or surgical area, this, extends from the lower edge of the orbit to the upper alveolar process. The upper wall constitutes the floor of the orbit, where the infra-orbital nerve runs. The lower wall corresponds to alveolar process, and the medial wall separates the antrum from the nasal choana. Indication. From a clinical perspective, the maxillary sinus elevation finds its ideal indication when it is impossible to insert inclinal and or short implants in the anterior posterior maxilla due to excessive bone resorption and the presence of large sinus cavity without thorns or bony septa. And then there is a residual bone base at less 2 to 3 millimeter. The space between the edentulous crest and the antagonist lower arch is at least 5 millimeter and no bigger than 12 millimeter, and absence of antral pathologies, exudate, cystic, neopolypus formation. The contraindications are general contraindication to implant surgery, the presence of large residual space between the edentulous saddle and antagonist arch, adverse relationship between root and crown, a residual bone base of less than 1 millimeter, the presence of bone septa in the sinus cavities, or need to call an maxillofacial surgery. The reclassification made by Professor Simeon helps us plan out the most appropriate treatment plan. Evaluates two parameters: distance from the bone crest to the amerocement joint CAJ for the adjacent teeth, and the height of the alveolar bone. Class A, bone crest is located about 3 millimeters from the CAJ of the adjacent teeth. The eye of the alveolar bone is at least 6 to 7 millimeters when the distance between the arch is normal. Treatment plan. The implant can be inserted following standard protocol or at discretion of the clinician with the technique of mini sinus lift. The crestal way using osteotomies. Regenerative procedures with GBR are not necessary. Class B. The bone crest is located about 3 millimeters from the CAJ of the adjacent teeth. The height of the alveolar bone is less than 6 to 7 millimeters, and the pneumatization of the maxillary sinus increases, and the distance between the arch is normal. Treatment plan. The implant can only be inserted following the standard protocol or at discretion of the clinician using the technique of a mini sinus lift. The crestal way using osteotomies. Regenerative procedure with GBR are not necessary. Class C. The bone crest is located more than 3 millimeters from the CAJ of the adjacent teeth. The height of the alveolar bone is at least 6 to 7 millimeters as the distance between the arch increases. Sometimes you need more than a vertical increases technique, and we also require an increase of thickness with GBR. Class D. The bone crest is located more than 3 millimeters from the CAJ of the adjacent teeth. The height of the alveolar bone is less than 6 to 7 millimeters, increasing the pneumatization of the maxillary sinus at the inter-arcs distance. Treatment plan: the increasing pneumatization of the maxillary sinus and the simultaneous accentuated vertical resorption of the bone crest must be managed by combining the large maxillary sinus elevation with a regenerative procedure of the vertical ridge elevation with GPR. Anatomical factor to consider: the maxillary sinuses are lined with a respiratory mucosa called Schneider membrana. The average thickness of the sinus mucosa varies from 0.1 millimeter to 0.5 millimeter. In the 30% of cases, there are bone septa, the underwood septa, lateromedial. Always originates from the base of the breast and are corticalized bone. The average height is 8 millimeter with peaks higher than 50 millimeter. The osseous protuberance inside the nasal sinus is very difficult to find, but it is found. The surgery becomes very complicated. On the medial, there are two communication cavities between the nose and the maxillary sinus: the lower meatus, antero-inferior, and the middle meatus or hiatus semilunaris. In 10% of cases, there are additional nasal communication offered. To prevent possible perforation of the sinus membrana, it is important to consider the angle between the vestibular wall and the medial wall to the maxillary sinus at the level of the planet osteotomy. At less than 30 degree, at less than 30 degree perforation is about 60% compared to between 30 to 60 degree, which leaves the perforation to 40%. The vascularization, it is anatomical area. In this anatomical area, is mainly given by an arteriole deriving from the posterior superior maxillary artery. And in the end is alveolo artery, antral artery. This arteriole has a high anatomical variability both in diameter and position. Tooth extraction can lead either to vertical bone resorption toward the maxillary sinus, leaving the maxillary sinus volume intact, or in the opposite direction with an increase in sinus volume, thus bringing the sinus floor closer to the edge of the alveolar ridge. Urist in the 65 was the first person to discover that free cell implanted on decalcified bone in extraskeletal sites simulated the formation of new bone. The responsible biological molecule belong the growth factor B and are called morphogenetic bone proteins, BMPs. Since then, the materials have evolved greatly. The main substitute now are autogenic bone is considered the best filling ever or gold standard. Innex, bone from different species, or alloplastic bone, complex synthetic origin. Some authors have proposed breast augmentation without the use of a grafting material in the sinus. The coagulate blood acts as scaffold for bone formation. The apex of the implant can be used to support the sinus membrana. Bone regeneration occurs as a result of this procedure, although the real clinical benefit remains in doubt since this method has not been adequately assessed through proper control procedure. Alternative technique to sinus lift. There are several therapeutic options as an alternative to the large sinus lift. These range from only grafts for vertical and horizontal bone augmentation, short implants, and inclined or zygomatic implants. The implants can also be placed in an angled direction to avoid the maxillary sinus. These implants are called inclined or angled and can only be used when the anatomical condition permit. The current research focuses on the evaluation of short implant positioning without bone augmentation, offering the opportunity for a less complex, less expensive, and faster alternative to the large maxillary sinus lift. There are few comparative studies evaluating the effectiveness of short implants. Now, Renoir 2006 defined an implant with lengths from 5 to 8 short, while Das Neves 2006 from 7 to 10 millimeters. Now, consider short implants 5 to 9 millimeters long. In this article with Canizzaro and Marco Esposito, to evaluate the effectiveness of long implants 10 to 16 millimeters inserted in maxillary sinuses augmented by means of the lateral windows approach, or short implants 8 millimeter positioned in sinuses augmented by a crestal approach loaded healing after 45 days. The conclusion of this article is short 8 millimeter implants together with a crestal sinus lift may be preferable to sinus elevation with the lateral windows technique, with simultaneous placement of longer implants in atrophic maxillary sinuses, with a residual bone higher of 3 to 6 millimeter, as they seem to be associated with less mobility. If these implants are positioned with an insertion torque more 35 Newton centimeter and connect under the same prosthesis, they can be loaded after six weeks. Technique of the large sinus lift. The surgical technique for the large maxillary sinus elevation for the insertion of the ostentated implants was first reported in literature by Bone and James in 1980 and then modified. It is adopted for the recovery of a sufficient height of residual velar bone in the reconstruction of several atrophic maxilla. Tatum, in the 1986, described 5 types of incision to perform the operation described by Bone: crestal, palatal, half palatal thickness, vertical and horizontal vestibular, and 3 types of bone surgical access: crestal, buccal, and Lefort 1. Tatum also described the 1-stage and then 2-stage sinus lift technique. The large sinus lift technique is considered a reliable technique and with predicable result if autologous bone is used as a bone filler. Lateral approach. One stage, diagnostic phase, amount of residual bone is in 2 phases, 1 stage and 2 stage. 1 stage, alongside the maxillary sinus lift technique, with or without the GBR, insertion osteointegrated implant in a single phase, surgical and contextual approach, more 3 mm thickness. Contextual surgical approach. Two-stage maxillary sinus lift technique, waiting 6 to 9 months and then insertion for osteointegrated implants. So surgical and deferred approach, less 3 mm thickness. Delayed surgical approach. In the pre-surgical protocol with patients are at risk, you should always give antibiotic therapy 3 to 4 days before intervention and continue it for another 3 to 4 after the intervention. For healthy patients and in simple cases, it is possible to give short therapy, which consists of 2 grams of amoxicillin and clavulanic acid 1 hour before the intervention and 1 gram 8 hours after the intervention. And Nasonex to sniff per nostril 2 times a day for 3 days before the surgery. Sinus lift technique, full thickness detachment, vestibular antrostomy, rotation instrument or piezosurgery, detachment of the Schneiderian membrana, extension of detachment of the medial GBR with bone or substitute, membrana e sutura. Vestibular antrostomy, the inferior margin of the antrostomy must be approximately 3 mm from the bottom of the maxillary sinus base. The upper margin 7 to 10 mm from the lower margin surgical area. Wait a second, please. Okay, sorry. Surgical chest form, rectangular, oval, anatomic. It is a surgeon's decision to choose how to perform the surgical access. Normally, if the surgeon is less experienced, there is the need for greater antrostomy. The initial detachment of the membrana must take place at the apical level to reduce the tension of the membrana. Sequentially, mesial, distal, and finally, the base of the sinus. The instrument must always be used seeking intimate bone contact. The mucosa has to be peeled off the medial wall of the nose. Why it is important to see the wall of the maxillary sinus? Because of increase in exposed wall and growth of osteogenic potential. Consequently, this helps the healing process, improve graft stability by avoiding pneumatization phenomena. It allows correct implant positioning. It maintains a physiological drainage of the maxillary sinus. Detailed step-by-step case laboratory approach. Radiography preoperatory, detachment, antrostomy plane piezosurgery, removal of the bone fragment and or overtuning and or bone recovery. Need to reach the medial wall, filling with a space maintainer, autologous, homologous, heterologous, or clot bone, possibility of covering with membrana and sutura. radiography pre and post operation. Now let's look at the crystal technique. Summer in the 1994 described non-invasive one-stage technique to elevate the maxillary sinus membrane and simultaneous insertion for the implants, minimum 6 mm, through the use of osteotomies. Concave osteotomies help to raise the sinus membrana to prepare the implant site. The technique is performed in conjunction with grafting material. In the 2000, Cauchy described a crystal approach technique using atraumatic cutters that reduce the risk of sinus membrana and lowers the crystal bone limit from 6 mm to 3 mm with one-stage technique. The CAS kit is a crystal approach technique with use of automatic drill that reduce the risk of perforation of the sinus membrana and lowers the bone limit up to 2 mm with the two-stage technique. This is a kit. This one is split into surgical section, prosthetic section, and another section. Clinical case. Okay. In this image, we see the pre-surgical CT section. Okay, and image before orthodontics and after orthodontics, before intervention. The residual bone is about 2 mm, and I am to recover at least 10 mm of bone. Step 1, incision and attachment. Step 2, first drill and then drill for diameter. Step 3, identify the sinus membrana. After hydraulic lifting phase, step 4, very slowly inject 1.5 cc of physiologic solution. Identify the sinus membrana, hydraulic lifting, and lift the membrana and fill the space with synthetic bone. This procedure is a very comfortable treatment. 4 drills and 2 stops for 1 cc physiological solution. Before and after. This case is a case for this video. Okay. Yeah. We're starting. We start by holding the flap open with an external suture. By doing so, we improve the view in intervention. The first cutter we use has a 2 mm diameter to 2 mm high. Okay. Is this. Perfect. Immediately afterward, you go up by 1 mm and use the drill with a height of 3 mm and a diameter 3.1. When the sinus membrana has been identified, hydropneumatics are used to lift the membrana. And when the membrana has been lifted, it is filled with synthetic bone, resorber membrana, and finally sutura. It's very comfortable treatment. Okay, now let's quickly look at the last case. Here we can easily assess the limitation of the crystal technique compared to the lateral access technique. In this case, residual bone higher, about 2 to 3 millimeter in this section. In this section, about 5 millimeter, but this is the underwood septa. Identify bone in the surgical site. I correctly performed the technique described in the previous case, the first drill, second drill, deep gauge, and lift with hydropneumatic elevation, the sinus membrana with physiological solution. We tried the Valsalva maneuver to assess integrity of the membrana. Once the membrana has been lifted, of course, it is filled with synthetic bone resorber membrana and sutura. But it should be noted that the inserted graft material was deposited in the horizontal wall of the sinus cavity, this area. I decided to reopen because the bone volume that was reached was not sufficient for the insertion of 2 implants. This measurement corresponds to the level of bone reached after the first crestal sinus lift. With piezosurgery technique, individual identification of the sinus membrana, removal of the bone and this point is very difficult to detach the membrana, very sensitive area. In fact, during the detachment of the sinus membrana, there was a perforation which was promptly repaired with a collage membrane. You can see the membrana positioned to repair the perforation and insertion 2 fixture 4 to 10 millimeter long. Pre-operative radiography and post-operative radiography. Okay. I think I think I finish technique and lateral approach with to summarize. This is how the technique to be compared the lateral approach with crestal approach. In the lateral approach, employee experience and the same in the crestal approach, but in the lateral approach, complex surgical learning curve. The crestal approach is a simple learning curve. In the lateral approach, minimum 3 sinus separate series and rotating and pies and or piezo surgery or implant and piece. In the crystal approach, 3 to 4 drills and solution, physiological solution and implant and piece. In the lateral approach, several post-surgical. The crystal approach, middle post-surgical. The lateral approach, of course, ability to manage an intraoperative complication. In the crystal approach, undetectable intraoperative complication. In the lateral approach, it's very important, limit anatomical variation. In the crystal approach, no limit, no anatomical limits. Post-surgical protocol. Antibiotic therapy, it may help to administer intramuscular cortisone in the interview area, talking anti-inflammatory and pain relief therapy as needed, local disinfection with chlorhexidine non-alcoholic solution to rinse a day after main meals, local cryotherapy for about 4 hours, abstinence for hot solid food for 48 hours, Nasonex to sniff for each nostril for 3 days after surgery, and sleep with 2 pillows at night. Thanks to all of you for being present. Guriam, I'm finished my presentation. Thank you very much.
So, please close the screen. It was a very nice presentation, and for what I see, your approach, your favorite approach is the, the small sinus lift with CAS, isn't it?
Yes.
So, how many complications did you have with it? Complications like membrane perforation and stuff like that.
Yes,
did you have
the few perforation, the few complication is perforation of membrana and sinus infection with bacterial. It's very, very complicated. Okay. And stop. But when you work in correctly procedure, you limit the complication.
Thanks. So, and also, how do you manage if you perforate?
Okay, I manage the perforated with membrana in collagen, or when you have a very good surgical hand, it's possible to suture the membrana, or I prefer don't perforation membrana, of course.
Yes, of course. That is, of course, what we all would prefer. But so if it's a big perforation, some clinicians, they leave it like this and try to reopen in 3 months or so. Is
Yes.
it what you would recommend, or you always try to feel it?
No, I recommend the close and reopen after 4 months or 6 months, of course. When a very big perforation is not possible to repair, it's problem. And I close and reopen, of course.
Of course, I would agree, because it's better to and the second time the membrane is also a little much thicker and more manageable after you do it in reopening in 3 or 4 or 6 months.
Yes. You think when you stay in operation and try the membrana, very sensitive, very whole, to help us with Nasonex cortisone and therapy for lower the inflammatory mucosa.
Thank you. Thank you, Doc. It was very nice to have you here today. And nice evening, because it's evening in Albania and Italy now. And I hope everybody was very, have learned something from this experience. And if there are other questions, perhaps you can answer in the comments later. So thanks again, and bye, and see you in the next webinar.
Okay, thank you, bye.
Bye.
Thank you very much.